now it gives me great pleasure to introduce the president of Friendship Heights Neighbors Network, Evan Smith.
Thank you, Louise. I'd like to welcome everyone and thank you all for joining us. Our program today is organized by Friendship Heights Neighbors Network. It's a volunteer-based nonprofit celebrating its 10th year of service to seniors in Friendship Heights. For those unfamiliar with the Village movement, we're neighbors helping neighbors to age at home and lead fulfilling lives. Dr. David Rabin proposed the end-of-life program to the Village Council and received a grant for it. That funding covers today's program, a second program at the Village Center on October 29th to review documents needed to develop an end-of-life plan, and free private consultations about a plan for up to 8 Friendship Heights residents who request them. We're most grateful for the Village Council grant, as well as the support provided by the staff of the Village Center. Dr. Rabin formerly led the Health Services Research Department at the Georgetown School of Medicine and the American Public Health Association's section on gerontology, and is a member of the FHNN board. He will now introduce our speaker, Dixcy Bosley. Dr. Rabin.
Well, thank you, Evan. All of us know the reality of death, but many of us don't fully accept the reality of its occurrence. Tomorrow, in a year, sometime in the future. Once we accept the reality of death, we have to plan for its consequences. You need to state what you want for yourself, your spouse, your children, your others. How does one make such a plan? We're fortunate to have Dixcy Bosley, a family practitioner, tell us what we should do. She lived through the experience of a death with parents, working with dying friends, and many terminal patients. Some planning, some who did not plan for the end of life. She became passionate for people to prepare for the end of life, fulfilling a responsibility to those left behind. Look forward very much to your talk, Dixcy, and thank you for being with us.
Hello, everyone. It's nice to be with you. I love Village people. We can start the slides, and I'll give a little bit more background. So I named this program Curiosity to Courage, and I'll share a little bit later about why I renamed it. But basically, it's an opportunity for folks of all ages to come together and think about our mortality so that we can live more fully. There's a great quote that says, "Tell me how you want to live by telling me how you want to die." And I think the more that we can create venues like this, which villages are pretty amazing for the many services they offer, but I think particularly having the programs and enrichment that you all provide is just a real plus to being part of a village. We can go on to the next slide. So part of my passion about doing these kind of programs and the kind of work that I do is because I did HIV/AIDS work in the 80s and 90s when it was pretty much a fatal disease. And all my patients died, and they were all quite young and professional and vibrant. And it really informed my life about what is living and what is dying, and how to help people have a compassionate death who were really suffering. It was a pretty horrible time, as you may know. I've done oncology and hospice nursing. I did hospice for about 20 years at community hospice before coming to Iona as a care manager. And I've done hospital chaplaincy. But I think my most informative part of end of life care is that I had a mother who was much older. She was 44 when I was born. And I feel like I spent much of my life learning about her thoughts on aging and being with her elderly relatives and going to nursing homes. And so frequently she would say to me, if I ever get like this, I want you to do this. She was happy that I became a nurse, and I became a real advocate and activist around end of life care because of my history with her, and also the patients that I had got to see through my early nursing in hospitals. Next slide. So what we're doing today is a little bit of a planning. I think that many of us, I just got a new induction range, and I did a lot of research for that new induction range. And I think a lot of times we spend a lot of time thinking about how we're planning purchases, but we don't really think much about how we're planning our end of our life and our later years, because it's a hard topic. But today is a temporary measure that we take until whatever happens, happens. We never know how plans will unfold, but I think that when you do plan, you have a little bit of better assurance that you can get what you want. Next slide. So the steps along the path that we'll take today are, we'll look at how we understand our own particular health at this time, how to talk with our clinicians, thinking about what matters to you, and also how to prolong life and prolong death, which there's a difference there, and how to communicate and then document. Next slide. So why don't we talk more about our goals of care? And right now, I don't know if we have a way of having an open response to this, but you can think about that question. We know that this is the trajectory. This image is pretty classic for many of us, but yet we don't talk about goals of care. We talk about early parts of our lives, but we never talk about the later parts of our lives and what we want. Next slide. I like this image because I think I feel this myself when I look in the mirror. It's like you see the earlier years of your life when you look in the mirror, and this is a daughter with her mom, and there's a lot of history in that mirror. And so a death-denying culture is one that we're reluctant to acknowledge the reality of our death, and that and we tend to avoid discussing it. But it's a great gift to yourself when you do, and it's also a great gift to family members. And we'll talk about why that is. So this slide, I think, is pretty funny because it's true. If you can, aren't you guys a little old to be listening to the rock and roll band? And he says, "We are the band." I went to a concert this past weekend, and literally, it did feel like most everybody in the room was gray-haired, and it was fun, but it was a reality that life moves on. Okay, so this image, I don't know if you can see it so clearly, but it's a little bit cut off. But it was a patient that I had within the last year, and he had lots of comorbidities. This is just a general, health form that I asked for people to send to me. And it has the conditions he has, the internist, all the specialists. I think there were 11 altogether. Recent hospitalizations and different, points of being frail. And so the next slide goes on to show all the medications. There were like 44 medications this patient was taking. And when I met him, he was in a lot of distress. The family was there. They were very educated. They had a high health literacy, as we call it. And I asked the patient if he would be interested in not going to any more doctors, and if he'd like to enter hospice because he clearly qualified. And he said, absolutely. And so then I put him on hospice, which was all new information for the family. And the next slide shows you that he was 97 years old. And for me, I just felt like this was another example of how we overtreat and over medicalize so many of our patients. at very end of life, you know, at 100 years old, we still are very aggressive unless the patient or the family speaks up. And I feel like this is a wrongful death in many ways. I think, you know, the medical industry has so much technology, and doctors are trained to treat disease. And as you get older, you keep collecting specialists. And so somebody needs to speak up and say that altogether, with all the different comorbidities, somebody could qualify for hospice, and then they can receive really comprehensive interdisciplinary care, which was very comforting to this gentleman. And he lived for another 4 or 5 months at home and got care at home, and he had a very peaceful death. Next slide. So the reasons why we have denial, these are just some that I wrote down that might relate to you, is we have lack of open discussions like we're having today. There's an overemphasis of youth and beauty, which, well, of course, we all know about that. Medicalization of death and dying as a medical problem to be cured. Fear of aging, a reminder of our mortality. Obsession with immortality and technology. Lack of rituals and ceremonies around death, which was very common, especially during COVID, where we weren't able to have memorial services and shivas and celebrations of people's lives. And then, of course, many of us have just a discomfort with grief and mourning. It's sometimes unbearable. I recently just heard a quote that I love that says, grief is love with no place to go. And I think that's just kind of says it all. So something that we all need to individually examine is how you see yourself. If you're young and healthy, if you're an older person and you feel pretty healthy, if you're struggling with a chronic disease or a serious disease, which would, you know, be a metastatic cancer, or if you're at a place where you're nearing death. So we're all kind of somewhere in one of these categories. And you can be old, you can be 100 years old and still feel pretty healthy, but it's really how you interpret your own livelihood at this point. Next slide. And then how we die is, you know, sudden death, car accident, gunshot wounds. You know, that we're exposed to sudden deaths a lot lately. Terminal illness, organ failure, which would be something like a liver disease or kidney failure. Chronic illnesses like congestive heart failure, diabetes, cardiovascular disease. And then frailty is something what they call failure to thrive, which you can just kind of be a dwindling old little lady that, you know, looks like she's got hardly any muscle on the bones, but people thrive and they can live a long time. But that is considered a category of the trajectory of end of life, frailty. Okay, next slide. So some of the steps that we want to talk about is, are you ready to have the conversation about death with yourself? Like, are you really thinking about, like, do you think about death, or what keeps you up at night when you think about your own death? And are you willing to just have the conversation with yourself? And then are you willing to have a conversation with somebody you love? And so that's important to think about, who are the people that are in my inner circle who love me and who I love, and I want to really have a confrontational conversation with. And then also with your clinician. And that's a really important conversation that can be billed separately on top, not a sick visit, not a well visit, but a separate visit covered by Medicare, where you can have a conversation with your doctor about your goals of care, you know, looking down the way based on whatever illnesses you have, or just planning ahead. And they can bill that as an advanced care planning visit. That's still available under the Affordable Care Act. We hope that it continues, because it actually saves Medicare a lot of money if we can have those kinds of visits with our clinician. Okay, so how long do we want to receive medical care is a question that we all have to ask. Quantity versus quality of life. And also, how much medical care do you want? Too much or too little? And there's people that, you know, want the medical industry to give them everything they can possibly have. Or there's other people who say, I'm willing to try a few things, but I don't want to spend the rest of my life going to a doctor's appointment. So that's also kind of a personal decision, and everybody can vary based on their own fears or their own fear of death or their fears of being overtreated. I have a personal fear of being overtreated, but anyway, okay, we'll go on. So the third step is conversation starters, is just thinking about how do we approach this conversation with people that we care about. So these are just examples. I need help with something that's important to me. Or if somebody in the family has died, it's a good opportunity to say, you know, that experience, this is how it affected me, whether it's positive or negative. Even though I feel fine today, it's I want to do this. If I'm unable to speak for myself, I'd like you to do this for me. And what does a good death look like to you? Because everybody has a different experience, and if you've had the opportunity to be with somebody who's dying, whether it was a terrible death or whether it was a positive death, that informs your own thinking about how you feel about yourself. And I think it's a privilege to be with people who are dying. It's a very sacred time, but it can be very terrifying too. But when it's a good experience, it can be very comforting. Next slide. So these are just ways that we can have the conversation. You might have heard of a death cafe, which is actually a national movement. It started in England, and it's been happening around the United States, I think, since the 70s or 80s. It's deathcafe.org if you want to go online, and it's an opportunity where people can come together as a village or a church community or a neighborhood group or just friends at a house and throw out a question, and then it just takes off. You know, they usually serve tea and coffee or snacks, and it's like a 90-minute process. It's individual, leadership. It's no professional leadership. And we have them at Iona once a month. And they usually 15 to 20 people come, and it's always different every month. Different people come and have different issues that they want to talk about. Death over dinner is another opportunity where, you might have like 10 people come together and have a question at the dinner table and try to be very intentional about keeping the topic on the question and not going off talking about politics or something else. Um, and then death positivity is a network of a lot of death books and lectures that happen. And then also death podcasts is a recording by a guy named Paul Williams, who records people's experiences around end of life and offers, if people want to do a podcast themselves, he'll record people. Next slide. This is just an example of some of the death cafes around the country. It's a little bit like an AA network where people can just go online, deathcafe.org, and find out where there's a death cafe near you. And in DC, they're happening all the time. Next slide. So this is a very dear friend of mine who had a disabled son. Fritz is about 60 some now, and he's in a community, and he is not able to take care of his mom. So Emmy Lou asked if I would be her power of attorney. And it was quite a journey. It was wonderful. She worked as in World War II as a munitions operator, and so she spent her last years at the soldiers' home as a former veteran, and she was just really an awesome woman. And she lived to be 101. And I would consider her I would consider her old healthy for much of her life. But anyway, we spent a lot of time talking about what her goals were and when she would want to go on hospice. And one day I basically said, I think your COPD will qualify you for hospice. So she was in hospice for about 2 years. And she got excellent care at the VA, at the veterans home. And you can go on to the next slide. We had a big 100th birthday party for her. It was kind of like a memorial service before she died in some ways. It was wonderful. But my point of telling you all this is that it gave us the opportunity, being on hospice long term, having very honest conversations. I felt like gave her really good assurance that she will have a good death. And she did have a good death. She, at 101, she was in her apartment and she fell and broke her hip, went to the VA hospital. it was clear that this was the beginning of the end. We're going to start morphine IV and help her die. And she was completely okay with that. So she spent the last week having lots of visits with friends and her son. And it was just a really good week. And I felt like because of the deliberate intention of what she wanted along the way, we could kind of help make that happen. Of course, the doctors in the emergency room were trying to talk her into surgery on her hip. But at 101, I told them that this was the therapeutic value of having hip surgery and what she'd have to go through was not worth it. It was not worth it to her. So she was really clear. And she actually had to teach the doctors how to respect her mortality and how to help her die, which they don't know how to do very well sometimes. And so she really instructed them. Next slide. So finding a good advocate is that you want to find somebody who will protect you and protect your wishes. And these are just qualities that I think are really important when you are asking someone to represent you. Whether they're trustworthy, whether they have integrity and they're assertive, if they're knowledgeable of the healthcare system and all the options, like does your POA know about hospice and home care services and things like that? Is your POA confident and objective? And mostly, underscore, does your POA understand what you want and your goals and your values? Because it's not what they want for you. It's what you have expressed to them, and you want them to honor your wishes. People choose friends and family. Sometimes they could have a constructive relationship, like somebody through a village or a church community. Or sometimes people have to hire a professional, like a lawyer, to be their POA. The risks of not having a POA is that you get a court-appointed guardian if you can't speak for yourself, and there's a lot of vulnerability and lack of control. So when we are talking with our physicians, these are just some things that are important to keep in mind, that you want to really understand the trajectory of your illness. Like if you have cardiovascular disease and you've had many stents and procedures done, you want to know like what could be down the road for me? What will it look like as my condition advances? What treatments might be offered to optimize my health? What treatments have potentials and benefits? If I want to live longer, how much more life would I expect? And I frequently will ask this question if somebody's being presented with like another chemotherapy round, like, if it becomes really toxic and the quality of life is really poor, are they willing to go through another round of chemo, and how much life is expected from that? And then also, what potential symptoms will I encounter? And also you want to know the truth, which is the real goal of the conversation. You want to bring a friend, somebody that can witness the conversation and help write down information. And if you can, I think it's a really great service that village members provide sometimes, to go to doctor's appointments with somebody and have a list of questions and be able to record and debrief on what the meeting was about. So this is just an image. Don't confuse your Google search with my 6 years of medical school. And the patient says, don't confuse the 1 hour lecture you had on my condition with my 20 years of living with it. So you are your best advocate is basically my message, that we know ourselves more intimately than anybody else knows us. And so it is important to say, these are the symptoms I'm experiencing over the course of my life, and this is what I need. Our doctors are there to serve us, but they have many patients with many issues, and we have to really protect our particular needs when we have a patient-doctor interaction. So this was another patient who was very special, and she lived a really full life, lived mostly in India, grew up in India, and she over many years of being her nurse care manager, we had conversations about what she wanted. Her physician, who was a concierge physician, did not agree with her goals of care. And he also didn't agree with my goals of care for her. But he kept wanting to send her to specialists. She kept denying, she'd make an appointment, deny it, make another appointment, not go. And I finally asked him if he would give her a hospice order because I knew she qualified, and he wouldn't do it. So I went to hospice. I went to JESA, Jewish Social Service Hospice, which is great in Maryland. And they qualified her. They have a doctor who's part of the hospice group, and they came out and qualified her. So she was also in hospice close to 2 years. She had an amazing, lovely caregiver, Dominique, who basically lived in with her. And it was just a beautiful experience. And she has a beautiful death. And so we were able to talk about her life up to her death. And then we were able to talk about what she wanted with some of her belongings and her cremains. So the next image, she wanted to be buried. You can go to the next image. Is she wanted to have her ashes go into the Ganges. And the gentleman with the white shirt is my daughter's boyfriend, and he's Indian, and he's like, I can take her to the Ganges. So this was a big comfort to the family, to have this, to know that her wishes that she had documented and expressed were honored. She didn't have a spouse. She didn't have any children. She just had some distant cousins. And they were just very grateful that she was able to have that long period of time to talk about her end of her life. So what happens when we don't get honest news, when, doctors have a hard time sharing bad news. It's hard to give and it's hard to receive. And we find out that most people don't get accurate prognosis. Many are over optimistic, and some are under optimistic, but usually they're over optimistic. And I think the goal is that we need to really know what our conditions are so that we can really plan ahead. This is Atul Gawande from Being Mortal. How we seek to spend our time may depend on how much time we perceive ourselves to have. And when we don't have an understanding of really how sick we are, or if treatments are recommended, but yet not in our best interest, we lose that time. And I have seen so much of that working in hospice, where people are referred at the very end of life. They have 1 or 2 days in hospice and then they die. And it's really heartbreaking. I feel like, especially with oncology, we do not have a better way of helping people decide how they want to spend the last year of their life. And hospice is only used across the board. It's 7 days or less is the kind of the national average, even though it is a benefit that can last for months. And that's a big loss for all of us. And it's a big loss for hospices too, I have to say. Okay, so what makes life worth living is really an independent thing. But for patients who I have experienced getting on to early hospice and having more actualization at the end of their life, I feel like they've had a good, life becomes really good for them. But we all have to think about what makes our life worth living. So this is just, if we were in person, we could maybe name these out loud together, but just to think about that. And the next slide is just kind of a list of things that, what makes your life worth living. Some people want to be alive at all costs to the last minute, no matter what. Being free of pain, able to engage in relationships, autonomy. People really want to be as independent as possible. And if they feel like they're a burden to somebody, they would just as soon not be alive. Retaining mentation over comfort. Engaging in work and meaningful tasks. Being able to live in your own home. And not being a burden to family and friends. And I think this last one is a huge factor that when people feel like life is meaningful and when it's not. If they're a financial burden, if they're an emotional burden or practical burden to their families, it might be a condition where they feel like they might want to shorten their life because they don't want to be a burden. And what I would say to that is having these conversations like we're having today, and doing the homework that we need to do actually helps reduce our burden factor on family members. This is just an image from Rock Creek. I found this couple when I was biking through, and I just felt like they're both big avid birders, and so they're both were seniors and engaging in what they love and trying to maximize the quality of life that they had even in later years. And sometimes it's a trade-off, if we're doing really aggressive care and we're spending a lot of time in doctor's appointments, we're not able to do the birding or the fun things that we want to do. So we all have to examine what brings our life meaning. Here are some things that we can ask our clinicians to help them, be a little bit more honest. Like, can you tell me what it is? I need to know so I can plan my life. You see a lot of patients with this disease. What is the pathway of my disease looking like at this point? Would you be surprised if I were alive in 5 years or 1 year or 6 months? And this is a common question that I ask doctors when I'm trying to get a hospice prognosis. Because if they say that the patient's probably under a year of life, I'm like, well, why are we spending all of our time going to doctor's appointments and doing aggressive care? Like, that would be like a turning point if the doctor were to say, I'm not surprised if they're gone. But we have to be advocates for that because it's typically not brought up as a first line of treatment. What are the benefits and burdens of treatments that the doctor's suggesting? What are alternatives? What happens if you don't pursue them? So that's something that, hospice has research on hospice has shown that early hospice actually prolongs living. So if you don't pursue a treatment, does that necessarily mean that you would die sooner or later? It's hard to know, but there have been a lot of good stories about early hospice and prolonging living. What do you choose to do if you were, this is a question that I ask every doctor. If this person was your wife or your husband or your child, what would you recommend for them? And that kind of gives the doctor we're kind of confronting them with our humanity and asking them to also confront their own humanity and to say, you have experiences in your personal life with people who become ill, and I want you to give me the same treatment that you would recommend to the people that you love. Doctors hate that question, but I think it's an important question to ask. Okay, so I renamed my presentation Curiosity to Courage because of this woman here who's in bed. She died about a month ago, but about 3 months ago, she was having symptoms. She was young, 71, a village member in another village. She was such an advocate for end-of-life programming. We did a lot of programs. She also did a lot of complementary care management visits with her village, like Friendship is. And she just was a big advocate. She came to death cafes. She just really was curious about end-of-life planning. And part of that was because she had a mother with dementia and she really wanted to kind of plan ahead as much as she could. So she was having some symptoms. She went to the ER and they found a glioblastoma, which is a pretty hard diagnosis. It is sometimes treatable, but it's usually not it's an aggressive cancer. So she decided in the emergency room she did not want to treat. And she told me that she did that based on all the conversations and death cafes and all the planning and thinking that she had done, that she knew that she had a limited time left. She didn't want to spend it on surgeries and chemo. And she chose kind of the path less traveled. But she was super aware, very informed. Her family was supportive. And she had a beautiful home death. Her memorial service is next week, and her husband was a complete champion to support her goals. And she was pain-free, and it was just beautiful. So I felt like her curiosity helped her be courageous. And she just was really a prophet to me. Okay. So we need to look at like what makes life worth living, what kind of quality. This is just a thing like allow for natural death, which is, DNR, or keep me alive at all costs. And depending on what individuals are going through, you have this process of like, maybe I'm willing to try this, but if this doesn't work, then allow for natural death. And, when we enter the medical industry system, lots of things are going to be offered. And sometimes you can decide, well, I'm willing to try some antibiotics, but I'm not willing to have a feeding tube, or I'm not willing to have a be intubated, which happened a lot during COVID when people were short of breath and struggling with COVID. They would say, I'm willing to have oxygen, but I'm not willing to be intubated. Okay, the next slide. So the ways that we do prolong living is that we put people on breathing machines of all different types. We use feeding tubes, either temporarily or we can do temporary or long-term feeding tubes. Dialysis, there's different types of dialysis, peritoneal, hemodialysis. Sometimes they use it temporarily, sometimes it becomes a permanent thing. Transfusions and also antibiotics are ways that we prolong living. But when doctors are asked what they would recommend for themselves, they usually do not choose heroic measures for themselves, which I think is pretty interesting. This Dr. Brock he's written several books on aging and dying, and he says dying doesn't cause suffering, but our resistance to it does. And that is so, so true. So this image is how to advance end of life as an opposition to what we just talked about. So people can be, if they're in an ICU on an intubator, they can be extubated compassionately, and sometimes people survive off an intubation if they've been dependent on it, and they can be weaned off, and sometimes they survive, but typically they don't if they were on long-term intubation. Sedation, palliative sedation is commonly used either in hospitals, or that's also what we used with Emmy Lou at the hospital after she had her hip fracture. Palliative radiation and chemotherapy just to control symptoms. Stopping a defibrillator, ICDs, and pacemakers is a way of helping people move toward end of life. Voluntary stopping eating and drinking. You may be aware that, folks are more interested in this option, especially in Maryland, because you don't have medical aid in dying in Maryland. So some people think this is a way of having some control. And, if some folks it goes pretty fast, and others it can be a prolonged situation. Stopping dialysis. Stopping an ECMO machine, which is a heart-lung machine. And also the last one is medical aid in dying for states that allow this procedure. And I just wanted to kind of update you about what medical aid in dying is. It's available in 11 states and the District of Columbia. But right now, with the federal takeover of DC, we're a little concerned that we may lose the law in DC. But right now, the law in most of the states requires two physicians, a prescribing physician and a consulting physician. And the first one does the assessment and does all the information. And it's very, very detailed, a long assessment. The second one will do a follow-up in 2 weeks. And then the initial one will be the prescriber. Psychiatrists are not typically needed, but if there is any hint that the person is suicidal, then they might bring in a psychiatrist. But normally, I've never seen this done. And then there's a pharmacist that will fill the prescription. And it's a private pay. And this is the prescription. It's usually like cardiac meds and narcotics and phenobarbital and medications that collectively will end life. And it usually happens within 1 to 4 hours of ingestion. And it's always self-ingested. The patient never is given the medication. They all have to be self-ingested. This is the medication. And also the patient has to both verbally request it as well as have a written request to do this procedure. And in terms of Maryland, it's been introduced for, I think, 4 times. And one of your village members mentioned that he's been to Annapolis and tried to lobby for the bill. Brittany Maynard, she was kind of a poster child. She was 26 years old, newly married to Dan, lived in California, but she had to move to Oregon, where it was the only state that had the bill, had the law, and she moved there when she had a glioblastoma. So her husband has carried on the fight, and he was in Maryland last year when we had a lobby day. He's just a great guy, and he carries on her fight for having a national law. Right now, there isn't. Like I said, there's only 11 states, and Maryland has really struggled hard to get the law, but there have been some hangups in certain jurisdictions. I just mentioned about DC possibly losing the law, but Compassion and Choices is an amazing organization that really fights for not just medical aid, but just end of life care in general. And I would highly recommend, if you don't know this organization, that you look into their work. They have a great guide that I'm going to talk about a little later. It looks like this. It's a toolkit. It's called Advanced Care Planning Toolkit. And it's comprehensive, and they just do a great work. I love this organization. Also in DC, we have End of Life Options DC, which is a new organization, nonprofit that just started as kind of a wayfinder for people who might be interested in learning more about medical aid and dying. And it's just an advocacy and education organization that I'm part of. Okay, so the best way that you're going to get what you want is if you can communicate and document. And several of us, family members, we haven't done this. We haven't had conversations with our families, our providers. A few of us have actually written down an advance directive. I think Sibley Hospital has gotten into a good habit of giving advance directives to the folks in the emergency room, just so that the language can be familiar. And it's a good thing that people are addressing it. But you can have the best plans, but unless they're communicated, it can result in excess treatment. So some people might choose to write a love letter to their family members just to express their wishes, which I think is a beautiful thing to do. And this is one you can just read. And we can go on to the next one. There's another example that a family member gave me, which, sometimes we're in the emergency room and have to make really fast decisions. And so this was something that preemptively that a person did. If you're in the situation where you have to make a fast decision, this is how they feel. I was recently in an ICU with a family member who I had lots of conversations with the patient, but the family members had not had as many conversations, and they were feeling really guilty about pulling mom out of the ICU. And I felt like this letter was this was not from the same patient, but it was kind of the message that I had to give the daughter was that your mother would not want you to feel guilty about prolonging her life in ICU because you didn't know really what to do. So this is just another example. Okay, so we need to know and document our end-of-life options. We need to know about palliative care versus hospice care. We need to understand about obituaries, memorial services, bequests, donations. These are just things that are important to share with people that you love. Organ or full anatomical donations, which have to be prearranged, of course, and traditional versus green burial. So these are just things that people might talk about or write down in their advance directives. We did an end-of-life expo a couple years at Iona, and I had organ recipients and organ donors. I had anatomical, which is a full body donation people. So that's just something that people want to learn about and learn if whether they want to sign up for that as to use with their bodies. Also, it's good to have conversations about what you want to lasting bequests or donations, things that if you have a collection of special art that you want donated. My friend who's into polar bears is a photographer in places where polar bears still survive, and she's already given away all of her polar bear prints to a university who studies polar bears. And she's not dead yet, but that's something that she has intentionally written down as part of her advance directive. Um, this gentleman in the gray is his name was Bob Hoffman, and he passed away very suddenly. But on his 75th birthday, he decided to have his birthday party at his cemetery plot at the Congressional Cemetery in DC, which is a beautiful cemetery. He was a docent there, and he told wonderful stories about the famous people who are buried there. And he got very sick very quickly. And because he had done so much work around end of life care, he came to my death cafes and he did a lot of intentional work. His family knew exactly what he wanted, and they helped him die well. And he had a great celebration at the Congressional Cemetery. His birthday on the 75th, and we had a celebration again when he was a couple years later after he had died. Green burial, just to kind of tell you a little bit about that, it's a natural way. Some people want to avoid chemicals and concrete and plastics and metals. And you can write this down as one of your wishes, just as an example. I ran into an organization in Nashville, Tennessee. It was like an Earth Day festival, and they had an incredible exhibit with wicker baskets and just beautiful things that they help people plan for a green burial. And I would love to go visit this place. And there are green burials in Maryland, green burial sites. So if that's something that interests you, I would encourage people to look into that. This is still part of the same organization in Tennessee. These you can go on. These are just different images I have. Some people choose to just have a shroud. And there's another image of you can go back one. That's a wicker basket that they actually help you make if people are interested in doing that. And then the last one is, I think, a pine box that there's an organization in DC called Holding Space, and they actually help you make your own pine box. So it might sound pretty strange, but for people who are into it, they're really into it. And I think there's a lot more options now, which is a good thing, that people are exploring what they want and having this all recorded. And it's a nice gift to your family members. This is just folks planting a tree at a site. There are more and more natural garden memorial areas, which is nice across the country, where people are not using, marble and concrete, but they're just putting ashes, cremains into a park. Okay, so ways that we communicate are through advanced directives, and there's many options. MOLS forms, PULSE forms is medical orders for life-sustaining treatment, or physician's orders for life-sustaining treatment. This is just a simple one-page form that people keep on their wall at home, especially if they're dealing with a condition, like mostly in hospice, where they'd have their MOLS form on the wall so that if anything happened, the EMT would look for that form. Hospital DNR forms, medical alert bracelets indicating what treatment conditions people have, letters like we had before, and videos like video podcasts where people can videotape what their wishes are. And here are just some tools, websites that have just so much rich information. And I would just encourage you to look into any one of these. because I think it's a comfort when it kind of the questions that are asked, it might trigger ideas. And it's just a comfort to know that you can record this and you can hope that the person who advocates for you will honor that. This is it looks like this. It's a little file for life, and it's something you can get through a fire department, but it's a 2-page, it's folded, it's put in, it's a magnet, it goes onto your refrigerator. It's another thing that EMTs often will look for with all your conditions, your emergency contacts, your health conditions, your health insurance information, allergies. And it's just a great tool. They also make it in wallet size where people can just keep this in their wallet. And you always write it in pencil so that you can, when your medicines change or if your conditions change, you can write it again in pencil. This is just compassion choices. If you're interested in getting one of those little booklets that I showed you before, this is the contact for the booklet. They cost like $1.50. I mean, she will give them to you for free, but if you make a contribution to Compassion and Choices, I'm sure they'll appreciate it. And they're very driven to help people have good end of life care. That's their main mission, and it's an amazing organization. I would encourage you to read and collect books if you're interested in this topic. These, of course, are some of the most famous ones that have been around. Being Mortal has like become a Bible. I think a lot of doctors are reading Being Mortal now. It was written by a doctor who was just kind of like a prophet that I don't know when that book was written, maybe 20 years ago, but 15 years ago. But it's really, it's just a really life-changing book for medical care and helping us kind of understand our mortality. And the one on the right is a kind of a funny book, but it presents really good information in a kind of a graphic novel way. Okay, next slide. And these are just some other books that I think I would highly recommend. Some are written by physicians, some are written by individuals like Diane Rehm. If I Ever Lose My Mind was written, and the one in the middle was written by a Episcopal priest at St. Columba who she's writing about her parents, but then also later her husband had some memory loss, and he was able to use her dementia directive, which she actually has in the book, about kind of being very granular about what he wanted if he's no longer able to speak for himself. So dementia directives are just a big deal right now because so many people are having memory loss. And if that's a fear that you have, it brings a lot of comfort to be able to record what you might want if your benchmark for what makes life worth meaningful for you. If you feel like you can't meet that benchmark, you might want to record. If I don't know the people that I love, if I'm unable to walk, if I'm bedbound, don't prolong my living. Do not take me to the emergency room anymore. Do not give me antibiotics. Do not prolong the condition that I do not want to be living in. And that's important to record if you're dealing with memory loss. Next slide. Just some other good books. You can go next slide. And this is just an image. I raise seeing eye dogs, and these are 3 of the dogs that served and came back. And so they're actually sitting right beside me right now. But the thing that I've learned about these dogs is that they're always together. They're always like a threesome. And I just feel like it's really important for us not to feel alone on this journey. And I think being part of a village is a very powerful asset. And many people in DC are aging solo. It's just the nature of our demographic here. So if you can, be connected to somebody else and share your own fears and struggles and resources, I think it really helps us on the journey. So just know that you are never alone, and there's people there that care about your values and can help you with your choices and support your goals.
Oh, okay. Are we ready for questions, Dixie?
Yeah, sure.
Okay. All right, the first question is, could you talk a little bit about doulas?
Oh, sure. So the doula movement is very similar to kind of the birth doula movement, where you hire a private person who has experience in birthing or dying. And the death doula movement is, or end of life doula, as they like to be called. If you go online and look for end of life doula, every town, every city will have a list of folks. And so you kind of meet with them and see if it's a good fit. But they usually show up when someone is moving toward end of life or in hospice or actively dying, where they might accompany you either in a hospital or at home and just be an advocate like they would be for a birthing experience. Um, and it is a private pay arrangement. So sometimes people might hire doula with like one contract over a period of several months, or it might just be a one-time visit. But doulas are a very powerful service that people seek. I know a lot of doulas. Some of them are people who have never been in the healthcare field, but they really want to do this work and they love it and they're committed to it. Other doulas are like former hospice nurses who have a lot of experience and they want to serve in this way. So I would, if you're interested in having a doula serve you or a family member, I would contact them and kind of see what their personal experiences are like.
Thank you. We've had a couple questions about the slides, and I just want to let you know that in a few days, not tomorrow, the slides will be available on our website. And if you have trouble finding the slides or you want a copy of the recording, please send an email to FHNN. We also had a comment, some hospice are equal to euthanasia. And I want to know what you think about that comment.
Some hospices are euthanasia. Actually, many hospices do not, they're kind of neutral on medical aid and dying. So I don't, I don't know what exactly the question is, but if somebody is choosing medical aid and dying, that is something that they usually do on their own journey. And then after the death, the hospice will come back and help with post-death care. But it's, you know, the experience of hospice is different for different people. I think as a former hospice employee, I feel like hospice is very careful not to advance people's death. I think they're very careful to do symptomatic assessments of symptoms and treat people as they find indicated. But I think hospice is very careful not to advance someone's dying. Which when people have home hospice, they have a lot more liberty to use medications as they feel they need them with the guidance of the hospice nurse. But when you're inpatient hospice, they're very careful not to, make you feel like they're killing someone. I just had a patient in the hospice at the inpatient hospice at Sibley, and her dying went on for weeks. And I was kind of surprised that she wasn't given more medication, but she wasn't because they assessed her every day and they felt like she didn't need any more medication.
Thank you. This person would like to know how you would get the 2 needed physicians for end of life.
Yeah, I would recommend that you contact the if it's in DC, that you would contact or whatever state you're in. There would be a wayfinder, like End of Life Options DC is a wayfinder, and you would get the referrals through that organization. They're usually not publicized just because it's a delicate situation. And in DC, we only have 2 physicians at the time. There are certain private physicians who will do it only for their patients. And we're trying to get more doctors to be part of the pool of doctors to offer this service because there is a big need. When DC passed, it was like 80% favorability for the law, but yet we only have 2 doctors and we only have 1 pharmacist who fills the prescription. It's a private local pharmacy. And that's because corporate pharmacies do not want to get involved in, because it's not a national law, it's just a state law. And so it's still, it's still hard to get medical aid and dying. It's I think in the district, we've only probably had 35 cases since 2017, since the law was implemented. Vermont has had a lot of cases because Vermont is a open residency state. So people actually travel to Vermont and Oregon to use medical aid if they live in a state that doesn't have the law.
Thank you. This question, or actually more of a comment, I agree with everything you say. I work in healthcare. There are a lot of doctors, like your example, would not put his patient on hospice. I advocate a lot for hospice. Patients, this is kind of a long comment. What can people do who do not have a you or a me in their corner? That's the question.
Well, I mean, that's why we're having this. Really, really want to share this information because I do feel like people need to be strong and equipped to ask the doctor if you have your own perceptions of somebody you love really struggling. It really requires us to say, do you think my mom could be eligible for hospice care? I mean, I learned a little bit about it, and I think it's comprehensive and interdisciplinary, and it'd help her keep her stay at home, and she wouldn't have to have any more doctor's appointments. Do you think she's eligible? And I think most doctors would say, oh, yeah, she is eligible. But the doctor will not bring it up because if they bring it up and you're not ready for the conversation, that means that they have to spend about another 30 minutes at least telling you about hospice and about the fact that your mom has a poor prognosis. So if we bring it up, if we initiate the conversation, most doctors will sign on for it. But they will not bring up the H word because we associate hospice with death because that's how we use it. We use it for 7 days or less. But if people could really understand the fullness of the experience and how people typically, not always, but typically they have a positive experience and they're able to do the things they want to do at the end of life, and their life is prolonged, then I think doctors support it. But we have to be our own best advocates and consumers. I think also we need to do a better. I mean, I cannot tell you the amount of patients, doctors that I've called and said, I think my patient should be on hospice. And the doctor doesn't even know how to make the referral. They do it so little that they don't know what the process is. And we need a doctor's order to say they have a poor prognosis, less than 6 months, and they need to initiate fax the orders, fax the records, and hospice can't be initiated until they do that. But they do it so little, they don't really know how to do it sometimes.
Thank you. This is a great question. For Maryland residents, does this mean one has to move to DC to ensure one's wishes are met? So I guess beyond that, what are
Oh,
other?
you have to fight to get the law in your state. I mean, Maryland is like 71% wants it, and your governor Wes Moore is ready to sign it. But there's a couple areas in Baltimore City and PG County that are still struggling with passing it. But I think it will pass the next time around. I mean, they have really been working. Delaware just passed, New York passed. Um, more states are added onto the list because people want it. It's democracy still. We might lose it, really. We might lose it across the country, but who knows? But you need to fight for Maryland, and DC does have open residency. So if people were to move into the district, get an apartment for a period of time, they could use it in DC or get an Airbnb.
Okay. Here's a question about Vermont, which I guess is more liberal. Once you travel to Vermont, how do you find the two physicians?
Oh, well, or call one of their agencies. I think it's called Patient Choices Vermont or something. You can just look up medical aid and dying in Vermont, and they have wayfinders. They have several organizations.
Okay.
I'm in a national coalition of MAID providers, and it's called Medical Aid and Dying Providers, and the coalition is actually really strong, and Maine has it. And so if I had a patient in DC who was a doctor who wanted medical aid and dying, he was shocked that there aren't more doctors who prescribe it. And I said to him, I'm like, well, you were a doctor. Why didn't you prescribe it? It's been around for 9 years. And he had no idea that there weren't doctors who prescribed. And so he wanted to go to Maine, to his home in Blue Hill to die. And I had to help him find a wayfinder in Maine to make sure that happened. So I just thought it was a really interesting thing that he had no idea that there's only 2 doctors in DC.
Wow.
So besides, I guess, Maine and Vermont, are there other states that people should be considering?
Well, I think Oregon and California are also open residency. But New Mexico's passed, Hawaii's passed, I think Montana. Like it is, if you go on the Compassionate Choices website, they have a list of all the current states, but they're always lobbying, and they also are always maintaining to make sure the law stays effective. Like that's the other thing. Is like, things change, and depending on the legislature of that given time, they may cut back. They might say, rather than a 2-week window between doctors, because people are kind of urgent to get the medication if they're really sick. And there used to be a period of time where you have to wait 2 months. Now it's a 2-week period, and that's great because people might not have 2 months, right? They might lose capacity to take the medication. And it's completely individual. Like there's no coercion, there's no giving the medication to anybody. It's really a self-ingested experience. And a lot of times people might get the medication and never use it. They just like to have it as a comfort in case they fear that they might have uncontrollable suffering.
Okay.
My feeling about suffering is if you don't want it and you don't believe in it, then don't use it, right? Like it's a human right, it's a bodily autonomy issue, and if you oppose it, then don't ever use it, right? That's okay.
Well, I think that's all of our questions, and I was going to turn the floor over first to Evan Smith and then to Dr. Rabin.
Well, Dixcy, I would like to thank you on behalf of all of us for an excellent and thoughtful presentation. I'd also like to remind everyone that you will be speaking again at the Village Center on October 29th. And also that there is the availability of individual consultations for up to 8 of the Friendship Heights residents that might choose to use it. But again, Dixcy, thank you very much for a wonderful presentation.
Yeah, it's nice to be with you all, and congrats to you for joining the group together and being part of a village, and just being open to something that's a really vulnerable topic. But I hope the information has been helpful and that it brings some comfort to you.
Dixcy, this has really been a remarkable presentation. Thoughtful, thorough, full of information, and your response to the individual questions were thorough and knowledgeable. So thank you for a special experience.
Good, thank you. Thanks for the opportunity to be with you.
Thank you. And I think we can stop the recording now.